getting down to a microphone. Good morning, everybody. It's a real pleasure to be here. Are we on? I don't know. Are we on better now? Oh. So thank you to the Diabetes Program for inviting me to give talks today. For 7 years, I attended the conference along with the team as part of the team, diabetes team at ANTHC, and it's kind of fun. Most of you guys I don't know. I do look around the room and see some old friends. I will point out that back in the early 2000s, our team, Judy, Dr. Edwards, Teresa and Miro were all part of the team, and it's so exciting to me to see them still on the team, to see how well the team has grown over the past 23 years. Let's not go there. So anyway, today I'm going to talk a little bit about the epidemiology of diabetes and where we are right now and what we can be doing within our own clinical settings to help improve our patient care. So let's see if we can do this. So I have no conflicts of interest. As Judy said, I'm a primary care internist. I do diabetes care up in Utqiagvik. We travel out to the villages as a team, helping our patients with diabetes in the villages and also at Utqiagvik, working with the primary care clinic. I'm not an endocrinologist. I say that off the top because that is not my area of specialty. It is primary care and taking care of the patients. So today, let's just have a quick look at the goals, what I'd like to get accomplished today. First of all, we're going to review the epidemiology of diabetes. Most of you guys here know this information, but at the start of the conference, it's important for us to see what's going on in the world, in the United States, and then in our own state to really understand why we're all gathered here today to help improve our patients' diabetes care. We're going to have a little bit about the complexity of this disease, and I've been in the field now for 30 years, and believe me, from when I came out of residency training in the mid-1990s to where we are today, the management of this disease has changed radically, and it's become more and more complex, and every year the complexity increases, and we as healthcare providers, whether you are clinical, nutritionist, educator, pharmacist, it's our responsibility and obligation to keep on top of all these advances. And quite frankly, it's very hard to do. Towards the end of this talk, I'm going to look briefly at tools that we have in place, and Vivian kindly mentioned one of those tools today that can help us in our clinical setting to try and achieve some of the goals we need to achieve to make our patients healthy people. And then at the end, I'm hoping to leave enough time to pass the microphone around, because many of the hopefully all of the sites representing here today, Alaska Native Healthcare, are doing innovations in their clinical settings, and I want you guys to share some of these stories with the group, but throughout the conference, this is your opportunity to talk to your fellow diabetes team members, and I say that on a state level, and learn a little bit about what other people are doing around the state that might help you with your own clinical setting. So let's start out and just say right off the top, diabetes is a global problem. 30 years ago, we thought this was only a problem in the developing world. Chronic disease was a developed world illness. Today, it is a global problem. This is, hopefully you guys can see this, but this is a map sort of like highlighting areas of the world where diabetes is prevalent. And I bring your attention to Africa, which is, everyone knows where Africa is, I don't have to point it out. But you'll see that the increase in diabetes in the African population is over 150% over the past period of years that this data was gathered. And they're looking at, actually, let me take that back and say that they are predicting by the year 2045 that the increase in diabetes in this population will be 150% increased. So you can see that everywhere around the world, the projection of diabetes is just growing exponentially. Even in the United States, it's expected there'll be at least a 35% increase over this period of time. There is no corner of the world that now is protected against getting diabetes, which is a sad statement. If we look at the global prevalence, we can expect this increase by about 200+ million people by the year 2025, And there, you can see on a world level, they expect there to be a prevalence of 8% throughout the world. So it's a defining disease of the 21st century. There's no question about this. If we look at trends, and these are people living with diabetes worldwide, 1 in 10 people in the world today are living with diabetes. And down below, you'll see I've put down predicted numbers from 1980, 2014, all the way through to 2045, and you can see this exponential growth. Over 3 to 4 people with diabetes are now living in lower and middle income countries, which is really quite shocking, as we always felt that it was a disease isolated to countries with plenty. Worldwide, this is a big problem. Diabetes is a very expensive disease, and worldwide there is expected to be an increase of costs of diabetes by over 300%, which is about almost I'm going to say $966 billion in healthcare expenditures worldwide. So to understand a little bit about what's going on here, we have to look at some of the leading causes. We have to look at the obesity rates in the world, and this is looking from the 1960s through to what is projected in 2030. And you can see that already this is an exponential climb up, but if you look at between 2010 predicted to 2030, that's only a 20-year span, and you can see the increase is quite shocking. And actually, I heard data at the annual American Diabetes Association conference earlier this year, that they said by the year 2060, 70% of the American population will have BMIs over 30%, okay? And that is if there's nothing changes in the way we are living our lives, which is, I thought, a very grim statistic. And if we look across the country, we see that where obesity is present, we see diabetes increase too. So here, if we're looking at this, the slides of the country from 2004, 2012 to 2019, you don't have to look at the little graphs underneath. All you have to do is look at each of these maps and look at the color gradient as we go across it. And you can see over the years the map has gotten darker and darker. And one of the things I always point out, at the bottom, they have the percentage. So the very light shows that 3 to 6% of the population has a prevalence of diabetes, whereas the darkest is 10 to 19%. And as this data has progressed, they've had to increase the bar as they go along because they have more and more data of people with increasing rates of diabetes. And here we compare diabetes and obesity together, and we know that obesity is a high risk factor for diabetes, and you can see the same graphs here that really show what I call the reddening of the United States. And this data only goes through 2010. If we had projected this out to 2020, we would see most of the United States now is red. And I just want to, I put down at the bottom here this little caveat, and we know that increased weight is a risk factor for diabetes, but I just want to make the observation that not all people who carry extra body weight have diabetes, and not all patients with type 2 diabetes are overweight. So it reflects the fact that there's a very strong genetic component to having diabetes that sets the stage, and then the environment that we live in often triggers the disease. So if we look at the United States, here's a snapshot. We know in the United States there are about 30 million people who are living with diabetes. So that's about 1 out of every 11 people have a diagnosis of diabetes. And one of the problems is diabetes, as you guys well know, is a very sneaky disease. And I tell my patients this all the time. You have high sugars, and I have patients coming into my office not infrequently with A1Cs of 14. I had a patient come in just last week with an A1C of about 16. And when you ask them how they're feeling, they feel fine, right? Maybe if you push them, they might tell you they have some increased thirst, dry mouth, maybe they're peeing more, but it's not something, if you happen to ask them, they're not going to tell you that. And one of the reasons being is tolerating a high sugar is really quite amazing. The patient, I had sent them for blood work, and the lab had called me It was like, of course, 5 o'clock in the evening. It wasn't a Friday, but it usually is a Friday, to call me to tell me the A1C was 16 and the patient's sugar was 650. So in most cases, you'd kind of hit the panic button. I didn't hit the panic button because I realized this patient for at least 3 months had been walking around with the sugars in the 400 range on average, maybe higher. When I called the patient to kind of tell them the news and asked them how they were doing, they were just fine, no problems. And we had them come in the next morning to start insulin. But it always amazes me how tolerant people are of hyperglycemia, and this is where it's challenging this statement that 1 out of 4 people don't know they have diabetes, because if you're not feeling too bad, you're not going to go and get checked, okay? So that's one of the challenges we have as clinical providers and diabetes team members, is try and identify these people, convince them that it's a problem, and then help them get onto a road to health and wellness. So the other thing that we need to just mention, of course, is prediabetes. Back in the day when we in the diabetes program were just youngsters, we used to call prediabetes borderline diabetes. How many people use the word borderline anymore? Oh, I saw a hand up over there. Okay, good for you. We used to say you can't be borderline pregnant. You're either pregnant or not pregnant. You can't be borderline diabetes. And the ADA actually came up with the term in the early part of the 2000s, whatever you want to call the 21st century, to call it prediabetes, to let people know that this is a diagnosis with an ICD-9 code or 10 code, and take it seriously that the risk of progression from prediabetes to diabetes is very high. But in the state of prediabetes, there's a very good chance that if people start making lifestyle changes or initiate medications in some cases, that the disease can be reversed or stabilized and not progress to diabetes. But again, you run the same problem. These are people who are essentially asymptomatic, and they just don't know they have a problem, which is where screening is so important. So let's look a little bit about Alaska. Vivian mentioned some of this information. I'm going to show 2 slides. The first one is obesity rates in Alaska, and this is data from 2015 to 2018. And you can see sort of spread around the state is where people's BMI is increased, okay? You can see in the YK in the Bristol Bay area, it's the lowest. Up in the Arctic slope, where I work, it's one of the highest. But if we go to the next stage and we look at the rates of diabetes, this reflects a little bit about my statement earlier about obesity and diabetes and the correlation. If we see here, we see in the Anchorage area, Anchorage service area, which is the biggest population, we see the highest level. Next is the interior, which is Fairbanks, clearly. And then the outlying areas, especially the YK and Norton Sound, have the lowest rates of diabetes. Some of this reflects change in lifestyle. When we started the diabetes program back in the late 1990s and we were teaching health aides, we would always ask the question, how many of you have diabetes in the villages, the patients with diabetes in the villages? And it was not unusual to have people not raise their hands. In other words, there was no diabetes in their villages. Now, in this day and age, sadly, all the villages in the Alaska Native Health System, there are cases of diabetes. And Judy, would you agree with that? Yeah, those days of no diabetes are gone. So I think I've already mentioned the fact that diabetes is a very complex disease. We know that it's the leading cause of blindness, traumatic leg amputation, stroke, heart attack, kidney failure, and periodontitis disease. And I put this down here because we forget about the fact that patients with diabetes can have very, very bad periodontal disease, periodontitis and gum inflammation, and that actually can really raise sugars and cause problems. So I put that in there just to give a little reminder to people to remember the dentist when we're thinking about diabetes. And if you see a patient clinically who's got really bad teeth, think about screening them for diabetes and asking the questions. But it is a complex disease. It is not all about sugar. It's about so many other factors that play into trying to build somebody on a road to a healthy life. Every 24 hours in the United States, and this is CDC data, there are about 4,500 adults are diagnosed with diabetes every day. There are about 136 people begin treatment for end-stage renal disease, and that means dialysis. There are about 200 non-traumatic lower leg amputations are performed because of diabetic foot ulcers and foot disease. And there are about 640 people die from diabetes or diabetes contributing to their death, and most of this is heart disease and stroke. So who should be caring for these people? I've just hopefully painted a picture of a very complex disease, a very difficult disease to identify, and a very complex disease to address all the issues that go with the presentation. Well, in 2014, the American College of Endocrinology, and endocrinologists are the ones who are trained, theoretically trained, well, I shouldn't say theoretically, there's nothing theoretical about it, who are trained to care for patients with endocrine disease, and diabetes is an endocrine disease. But the problem is there are not enough endocrinologists to go around. And the American Endocrinology Society has predicted that by the year 2025, which is, 2 years away, there will be a shortage of almost 3,000 physicians, endocrinologists, to care for patients with diabetes. So it makes sense that you can't refer your patients to an endocrinologist who have uncontrolled diabetes. My patient with the A1C of 16 and a sugar of 650, there is no way I can refer that patient to an endocrinologist for care. The ratio of endocrinologists to adult patients over the age of 65 is 1 to over 6,000, okay? And this is true throughout the United States. And the average waiting time to get an appointment with an endocrinologist on a national level is about 3 to 4 months. How many of you have tried, if you're clinically in the audience, referring to an endocrinologist or have tried to go to see an endocrinologist? Anybody referred in town, in Anchorage? The wait list is phenomenal. It's either no, we have no room, or it's 8 months plus. So what I'm trying to say here is the endocrinology office is not where we're going to treat type 2 diabetes. There is no question that this disease has to be delivered in the primary care clinic. And in Alaska, probably about 99% of our diabetes care takes place in the primary care setting. Very, very few patients are referred out to the endocrinologist. It's usually our patients with type 1 diabetes or who are on a pump who need additional help beyond the scope of the primary care office. And the treatment and the technology for the treatment of diabetes has evolved rapidly over the past, I would say, 10 years. And it's a big challenge for the people on the diabetes team, I believe, to stay up with this technology. And the diabetes guidelines that are put out by the American Diabetes Association. So when we're thinking about this patient, we need to think beyond just glucose, and I call it glucocentric. We can't just think that their problem is sugar and getting their sugar under control. We've got to think of all of the rest of their issues, their heart, their lipids, their blood pressure, their kidneys, their feet, their eyes. And as you can imagine, that makes for a very busy clinical visit. Now, I don't want you to look in detail at these charts, but I want to put up these so you can kind of look at this as the complexity of what we're dealing with when we're treating our patients with diabetes. This is the Standards of Care for Diabetes 2023 put out by the American Diabetes Association, which is really the key organization that we look to when we're trying to figure out how to care for our patients with diabetes. And this one chart here is the decision cycle for person-centered glycemic management of type 2 diabetes. And when you look at this, they are asking that when we are addressing our patient care, we are looking at all these levels moving through this circle, whether it's assessing key person characteristics, who is this person we're treating, what are the treatment factors we have to decide when we're considering a treatment plan, how we're going to get the patient involved in the decision-making process, how we devise an agreement on a plan, and on around. And you can imagine that this is a very busy, time-consuming, and demanding process, but the American Diabetes Association feels that it is part of the necessary care for our patients. So one of the areas that has changed radically, as you all know, is the treatment of medications, okay? This was a study just looking through 2000, and the number of patients on a national level that were treated with at least 5 medications had increased from 8% to 30%. And here's the problem. The time spent with the patient visit actually only increased by about 20 minutes. How many minutes are visits long? How long are visits in your facility? Anybody want to shout out how long provider visits are? 30 minutes. So most places are 30 minutes. Some places will do 20 minutes, okay, where they are in the private industry, but 30 minutes in Alaska is reasonable. So how much of that 30 minutes is spent doing the intake? 5 to 7 minutes on average. What was the word down there? Did someone? 15 for the intake down there. So someone said 15 for the intake. So if you've got a 30-minute visit and say 5 to 7, sorry you guys, speed it up, okay? Come on, it's too short. Are doing intake, and our intakes now in the primary care setting, as you all know, are requiring screening for depression, smoking, all important issues, domestic abuse, medication compliance, the nurses having to do the med reconciliation right. So by the time the provider comes into the room, all of this work has been done. The time that the provider can actually spend with a patient without going over into the next appointment becomes very limited. Yet we are asking the provider to do more and more work with that visit to address all the aspects of care. Now, I put this up here, and again, I don't expect you to read this or even be able to read it because the print is quite small, but I want you to just look at this list. This is a list of medication-lowering medications for diabetes, and it's not even complete. I had a patient who came in a couple of weeks ago who was on acarbose. How many of you know what acarbose is? Good. Oh, yay, hooray, okay. How many of you have seen a patient on acarbose recently? Nobody, but, well, okay, good for you. It took me back because I haven't seen acarbose for years, but I had to know what it was. I had to understand why this person was taking it, and I had to be able to ask about side effects associated with that medicine. So when I came out of training and I joined the diabetes program, we essentially had very few medications at our disposal. We had metformin, we had glycerides, the sulfonylureas, and we had insulins. We did not have fancy insulins, we just had MPH and regular insulin. When I came onto the program in 2000, the TZDs had just come on the market, and I remember the first telephone referral I got, and the provider was asking me, it was like from Nome or somewhere, the provider was asking me about rosiglitazone. I remember, and I'm not embarrassed to say this, I remember having to say, look, can I just call you right back? And hanging up the phone and desperately going to the books because we didn't have much in the way of computers, really. And reading up what the heck was rosiglitazone, I had no idea. Worse yet, when I was in residency and metformin first came out on the market and my first patient came in on metformin, I remember thinking, what the heck is metformin? Nowadays, it's not just one or two medicines we have to know. It's this huge list of medications that involve the DPPs and the SGLT2s and GLPs, all these fancy initials. I'm just going to make a little caveat here and say that without question, standing here today in 2023 to this audience, I will say that the SGLT2s and the GLP-1s have made a radical difference to patient care. Would you guys agree? I am now seeing patients who we've started on these medications who are having amazing improvements in their A1Cs. And it's exciting for me to think that we do have medications on this list now that are positively impacting our patients. And for me, it gives me hope when patients come into my office to see me that I can help them make improvements in their diabetes care. So that's my little plug for the medications. But as providers, whether you're a diabetic educator, if you're a nutritionist, if you're a podiatrist, if you are obviously a pharmacist, you have to know these medications. You have to know their side effects. You have to know how they work. And that can be very challenging. So let's look briefly at the IHS audit data. And this is, I took this information off the audits from 2013, 17, 22, 23. And you will see, if you look at this data, that we are definitely increasing our medication uses. If you look at no medications, we are shifting from 20% in 2013 down to only 14% of our patients on no medications. And mostly because metformin is now the platform on which we build our diabetes care. But if we look all the way down to 3 and 4 medications, you'll see a radical increase in the number of people who are on 3 medications and 4 medications. And we don't really track out more than 4 medications. We haven't tracked out 5, but it may be something the audit needs to add, because now with insulins and orals, many patients I have are on can be up to 5 medications. So this again just reflects the more complex management of these patients. And then just to add salt to the wound, this is the American Diabetes Association's algorithm nowadays for trying to decide what medication to start on a patient. And it's not anywhere as easy as it was 20 years ago. Now you have these very complicated algorithms where you're looking at their chronic disease, their labs, their health issues, to try and decide which of all these medicines is the right one to give them, and then consider side effects, which ones they will tolerate, and then if building a platform of medications that will get them to goal. I will say that I told you that I think that the SGLT2s and the GLP-1s have radically changed our management of diabetes, and maybe you guys will agree that continuous glucose monitors have also radically changed our ability to help care for our patients with diabetes who can use these devices properly. How many people in this room are involved in the placing and handling the great? So, hey Lisa, how are you? So I would suggest you spend some time and talk to Mimi out at the Abbott table today. There's some incredibly great information about using the Freestyle Libre 2. Maybe some of you are using 3s. Anybody using the Libre 3 yet in their sites? Good, okay, that's really great to see. So I think that this has also changed our ability to help patients with diabetes. But again, it complicates the patient's visit, right? Because you want to start a Libre on them, you have 20 minutes, and how is that going to happen? So to sum up what the American Diabetes Association is recommending, this is what they suggest we do at our first visit for diabetes and for follow-up visits. And again, I don't want you guys to read this all the way through, but I want to just put up the complexity of these visits. And the reason I've left the letters up here, the A and the B, is because the data the ADA is suggesting is necessary for a complete medical evaluation of a patient with diabetes. If it says A, there is clear evidence from well-conducted and generalized randomized control studies with power to say that this is statistically significant advice built on very good studies to suggest that it improves clinical outcomes, okay? So what are the visit needs for a patient with diabetes? Well, I sort of made this list up myself, trying to think of when I have a patient, what I'm trying to do in the office. And if you have a physician-centered care, these are all the things that we need to do in a visit as a team or with the physician. And you can see that it's a very long, complicated list. And I'm sure if you guys look at this list, you're going to think things that I've missed out on, okay? But the idea that we have to do screening, we have to find out what's going on with their lifestyle, we have to review labs, we have to see if they've had labs, if they've had a CGM, we have to do CGM reviews, we have to look at their medications, we have to do refills, we have to look at, do a foot exam or refer them to podiatry, we've got to think about education, interact with the patient, do our physical exam, and it goes on and on. And as you can tell from this list, 20 minutes, it's just not going to work for the provider to do this. You only have the 20 minutes for the visit once you've taken away the time to get the patient settled in to start the visit. So what I'm really kind of saying here is that creating any sort of high-quality comprehensive care takes a team. How many of you there now are working at sites where you have an established diabetes team to help with your patients? Okay, so some hands put up, but not a lot of hands. It would be nice to see this room one day when that question's asked where everybody puts up their hands, because the only way to truly manage patients with diabetes is through a team approach, okay? it allows you to expand the visit far beyond the provider and patient interaction, to bring the patient into the center and have the support groups around that the patient that can be used to help support the patient's care. So it's patient-centered. This is the patient-centered medical home model. Does anybody use this particular model in their facilities? Okay, it's a national model that was put together by maybe CMS, I'm not quite sure, I'm pretty sure it's CMS, as a model for clinics to use to try and improve diabetes outcome. It improves costs, it improves patient satisfaction, it improves team satisfaction too. And it's really allowing the team to support the provider, to support the patient, okay? So if you're going to build this idea of working together as a team, you have all these different sub-people who can help: the medical provider, the nurse case manager, dietitian, exercise specialist, pharmacist, dentist, podiatrist, optometrist, mental health providers. These are all people who are part of the team. So if you have a patient who needs podiatry referring, dental referring, optometry referring, and then you need to follow and see how well these patients are doing at meeting these needs. So this is, how many here work for South Central Foundation? Okay, so you guys are welcome to comment when you have our comment section, but back some years ago, South Central Foundation started to develop what was called the patient-centered team approach, where if you look at the left-hand side with the provider in the center, where the provider is left to do all the support of the patient, they changed their model over to the other side, where you have case manager, the provider, the certified medical assistant, the behavioral health consultant. All of these are working together to provide the services that the patient needs. And I think that it's been a successful model, and this now is a nationally used model that seems to work well. And I hold that up just as one example. The other thing that can be very helpful in developing your team is using the medical electronic record. And clinical pathways that are built into the medical electronic record can be helpful. How many people who are using Cerner? And are you using the dashboard in Cerner? Okay, so Mira, who is right there, Mira, stand up for a sec. I know, this is Mira. So Mira has been very instrumental in developing the diabetes dashboard in Cerner, and if you're using that medical electronic record, it can be an incredibly helpful tool for the diabetes team to remember what are the patient's needs. Are they doing A1C? Do they have lipids? Are they on an ACE? Should they be on an ACE? Is their A1C high? Do they need to have their medications adjusted? Am I right, Mira, along that kind of lines? Okay, a nod, good. Okay, so I would definitely say during this conference, if you have an opportunity to interact with Mira, if you have any questions about the dashboard, other medical electronic records have these clinical pathways built in to try and help manage the patient and have the team know what the patient's needs are. So we know that it positively influences quality care and patient outcomes, which is what we're really all about. So what are some of the barriers? And I'm going to get you guys to call out now. What are some of the barriers of building? Why didn't everybody in the room raise their hand to say that they have diabetes teams working at their facility? Well, I can tell you some of the things that I have learned from being up in Barrow. Building a well-integrated diabetes team is hard work, okay? We have problems with retention of medical staff. We're always having changes. We have a terribly hard time hiring certified diabetic educators because we just haven't been able to attract anybody up to Barrow. Our nutritionist, who at the moment is wonderful, we hope she stays, but I have a feeling she's a marathon runner, and living in Barrow, Alaska is not the place to live if you want to run marathons. Recruiting people up is very hard. Getting buy-in from the stakeholders to try and give us time to develop the tools that we need for our diabetes. Formula limitations. I don't know how many of you have limitations trying to prescribe SGLT2s and GLPs and some of the more expensive medications now, some of the more expensive insulins. We see a large percentage of non-beneficiary patients up where we are, and formulary is something we have to keep in mind. And then another challenge we've come up with is trying to have a system to get CGMs on patients in a well-organized fashion. We don't have it, and it really is chaotic when we're trying to put CGMs on patients. What else? What are other barriers people have run into? Just shout it out, and don't be silent, okay, guys? Culture, kind of considering, and for us up in Barrow, we have, 4 major cultures that we deal with. We have a large Filipino, Fijian, as well as our Alaska Native population, and then other people in town, and everybody's a little bit different approach. You're right, culture. So thinking about the patient in the center and their cultural preferences. Anything else? Funding. Funding is a big one, you're right. And we run up against that all the time, trying to do something and trying to figure out where the money's going to come from to increase services, yes. Medication shortages, yeah. Or, say again? Patient adherence, okay, and that's always a really tough one. You know how we say that, let me look at the time and see, oh, shoot, I went at light speed, didn't I? Patient adherence, and we use the word non-compliance, and as you all know, that's something we do not like to say, patient non-compliant, because it implies that you have someone who just doesn't care and isn't going to do it, which is often not the case. Part of patient adherence is trying to understand why. What is it about the patient that's made them decide they don't want to do this, or they don't want to take their medications. And I think everybody has barriers, and it's our job as providers to try and figure out why somebody has got a different agenda than what you would like them to have. I think that's a good way of putting it, maybe. Anything else? Location and travel logistics in Alaska is a big one, especially if you've got patients out in the villages. One of the reasons in Barrow we're trying to take the diabetes clinic, our diabetes team out to the villages is to try and meet people on their home ground. We've actually found it's really increased the number of patients with diabetes that we can see out in the villages, as Kim, well know. Kim is part of our Barrow diabetes team, as is Jennifer right over there. Anybody else think of barriers? Judy? Come on.
Getting people in the door sometimes, like our first referral is always hardest, like getting people so they can become an appointment.
And then that is very true, and one of the questions I always have is, how much do we nag? And seriously, say again? 3 strikes and you're out. Well, we did a health fair up in Barrow 2 weeks ago, which you guys are aware of, and of the 60 people we screened, over 53% had normal A1Cs, which means 47% had abnormal A1Cs. It's kind of shocking, isn't it? And of that 47%, most of them were pre-diabetes, but we had one who screened with an A1C of 12.1. So, what do? Well, you call them and you make an appointment and have them come in, and then they don't show. And so you call them and reschedule, and they don't show. And you call them, and then they start saying, stop calling me. And at what point do you do the Judy approach, which is 3 strikes, you're out? At which point we do get accused of nagging. But then when do you decide? That's what I agree with Judy. They'll come back to you when they're ready. Sometimes it might be through the emergency room, which is me being cynical, but they will come back. But I do believe my philosophy has always been an educated consumer is an informed consumer, and you have to try and help people understand. In order to make their choices, they have to understand what's going on. Anybody think of anything else?
Another barrier is the 15-20 minutes that the primary care provider has with the patient. The pre-diabetes is way down at the bottom of the list. And so the barrier is getting to that pre-diabetes during those provider meetings somehow kind of
Prediabetes is a problem all unto itself, and I agree. And do you schedule clinic visits to bring people in for prediabetes discussions? Just thinking outside the box, prediabetes is a perfect opportunity to do group diabetes, meetings where you bring people in as a group who have been diagnosed with prediabetes to do education and information. I don't know does anybody do group visits here? Did that fall by the wayside? Oh, that's right, yeah. COVID, for me, I spent COVID at the South Pole, so I sort of missed out on I seriously missed out on COVID. I was totally on the other side of the planet for that whole year. That was a surprise. Okay, so I want to open up the rest of this time that we have, and then we'll take a little break if that's okay. And this is our diabetes team here, okay? So this is Teresa, sorry, I said Teresa. Rebecca is our nutritionist, that's me, that's Dr. McKeever, who is our podiatrist, who is 6'7", and quite a character. And then that's Nikki, the nurse. We are out in Nowitzik Village. We went out there and we actually saw 10 people with diabetes during our day visit. And we felt that was a very successful clinic. And we try and bring out education, clinical care, foot care, all at the same time. So would anybody like to get up with the microphone and talk a little bit about what they're doing in their site? Nobody?
Here, we have somebody.
Okay, good.
So I've actually am a certified wound care nurse and foot care nurse and transcultural nurse and go on and on. One of the things that we've done is we've integrated wound care along with diabetes. I'm a nurse educator as well. And having the opportunity to care for patients with diabetes who are pre-diabetic and have diabetes, I have a chunk of time while they have a wound, they're vulnerable, they're at a point of realizing something's wrong, and it's gone really, really well. I get to educate and do wound care.
Don't be shy, guys. We're a friendly group here.
Hi. Whoa. It is on. Okay. So I'm Crystal, and we are starting a diabetes care center on the Central Peninsula, ground up. It's an empty building right now, and we have our nurse practitioner, Anya Boudwell, who will be the provider in the clinic, and then I'll be one of the diabetes education nurses, along with Brian, who will be with me as well, and we're just starting from scratch here, and we're really excited that the hospital is supportive. We have a lot of stakeholders already, and we're ready to get going here in the next couple weeks.
So that's a perfect example, really, of building a patient-centered care system. And how are you getting your referrals over? Are you having primary care providers refer over to you, and then you're stabilizing the patient and referring them back to their primary care provider?
Yes, exactly. And Anya already sees several patients with diabetes as kind of a diagnosis, so we're making that transition as well to the center.
So I think that's a very exciting approach to diabetes care, and kudos to you guys doing that out on Central Peninsula. I did read about a small study in rural, I think it was South Carolina, where they took this idea, sort of what you're doing, but on a smaller scale, which is something worth thinking about. Within the primary care clinic, they committed a half day a week with a provider who was invested in diabetes care, along with other members of the team. And that half day a week was to see patients with diabetes whose A1Cs were above 8 and referred over from other primary care providers. So the patient would come over to that little subclinic, be seen, patient-centered care with the team, meet their needs through the members of the team, and then when their A1C had stabilized, they would go back over to their primary care provider. And I thought that that was a very good model that could be practiced certainly throughout Alaska, because it wasn't asking to bring in special resources, it was using what you had on the site. And that's something certainly for some of the regional sites, it's worth thinking about doing that. You need to have people who are invested in understanding the medications and the patient's needs, but I think that could be a successful model to try. And I know I've spoken to Kim about us trying something similar out in Barrow, so we'll see if that gets any traction. with our patient population. Anybody else?
People with diabetes, and it's just a really important service for patients, and it's an opportunity to be part of the team and work together.
And Lisa, I agree completely with that, and something we didn't really cover when we were talking about the complexity of the patients. And Dr. Edwards is going to be giving a talk tomorrow about feet. Is the diabetic foot exam. So we're doing an initiative in our diabetes clinic to try and see if we can get everybody who gets seen get their diabetic foot exam. And with Dr. McKeever's help, I think we're doing pretty good. But there are other ways of getting the diabetic foot exam done than just having the provider do it. I remember in the day we used to say, take the patient's shoes off when you're doing your vitals. So when the doctor comes in, the feet are already bare. I think that makes people uncomfortable. I don't like to do that. But it doesn't have to be provider-driven doing a foot exam. A foot exam is one of the easiest exams. It takes, how many minutes does it take to do a good foot exam, Dr. Edwards? 2, okay. Boo. Double it, okay, because Dr. Edwards knows what he's doing down there. But it doesn't take more than 2 to 5 minutes to do a good foot exam. It's an opportunity of education, and anybody can do it. You do not need to be a podiatrist or trained nurse practitioner, PA, or physician. And that's something where a patient is waiting, there's downtime. It's an opportunity for a nurse to do a foot exam. If the doctor's running behind, there are lots of opportunities to get that exam in. And one little caveat before I acknowledge you is please document that you've done these exams, okay? So we know then that the patient has had a normal monofilament exam done for the year.
Thank you for mentioning that. That's something that I took away from last year's conference and was able to train my medical assistant to do the diabetes foot exam, and she's done an excellent job right as her part of her rooming and only leaving the patient barefoot if there's a problem that I need to look at. She's great at documenting, she's checking pulses, monofilament, she's doing vibratory sensation, answering questions, and even providing some of the education about foot care, reminding patients. So having a medical assistant involved in that has been really great, and I think it also empowered her in the passion that she has to care for the patient, gave her some really great, opportunity to serve the patients in a different way and get a skill that she really likes. So I would encourage others to consider your other staff for the diabetes foot exam.
Thank you. Yeah, I think that's excellent point. Somebody over there.
Hi. So we have a provider that's part of our team, which has made a huge improvement. Several years ago, we had Jocelyn Diabetes Center come out and consult and tell us how we should run a diabetes program.
Where are you from?
Bethel, YK. Mm-hmm. And Jocelyn Diabetes Center talked a lot about what you talked about, where it's a disease of primary care and it doesn't require a specialist and everybody needs to address it. But I think what happens is that not everybody feels comfortable addressing it. And so when you don't have a champion provider or a specific provider that you know will do a great job and will be thorough with their review and comfortable starting new medications, the patients don't get the best care that they can when there is a dedicated provider. And so it was about 10 years in between having a provider with the diabetes department. We didn't have one, and now we have one again, and it's in our patient care.
And you make a very good point there, and this is a frustration that I have as a provider. You guys out there who do clinical care, nurse practitioner, PA, physician, why don't we feel comfortable about carrying a disease that affects so many people? Why aren't we comfortable knowing what the new medications are? It's not really rocket science, but it takes some time. There's CME online now. There is no reason that providers can't keep current with the needs. And, do you think providers would say the same thing if it was a patient with COPD? Oh, I don't feel comfortable taking care of COPD, so I don't want to really see them, or heart disease or liver disease. I'm not quite sure where the complacency towards treating diabetes is it's because it's so complex and demands a lot of thought and time. So I kind of get a little discouraged when I hear that sites have problems getting providers empowered to and we have that problem up, there's no question, up in Barrow. You know, some providers just are not interested in caring for the patients with diabetes. As a primary care provider, I find that very hard and a little sad. I think the only thing you can really do is try and encourage the providers by, I don't know, pointing out CME. Do you hold and monitor them? I don't know the answer to that. I really don't. And I'm sorry. I'm glad you guys have got somebody out there now. But if you find somebody in your clinic who is passionate about taking care of patients and taking care of patients well with diabetes, then you have to grab them and you have to nurture them, water them, feed them, pat them on the back, make them feel part of the team. And this is one of the things when we went out to Nowitzik, we felt like a team. We had a great time. The patients picked up on the positive vibes, the health aides did, and I think that's what you need. You do need impassioned people. It's hard. I hope Bethel is enjoying the new provider. Anyway, okay, so I hope this has been helpful. It's a tough subject to talk about in a kind of meaningful manner, but what I'm trying to start the conference off by saying, everybody in this room here is part of a large team, and that's our Alaskan Native healthcare team of diabetes people. We are a team, okay? And your job over the next couple of days is to, as like Judy said, make a friend, make new friends, talk around yourself. You're all here because you have one common interest, and that interest is to provide the best diabetes care to your patients with diabetes and to make their health and their lives better for it, okay? And I think we need to commend everybody who is sitting at tables here today for coming and wanting to improve their diabetes care. But I also want you guys to try and carry back some thoughts from this whole conference that you can take back to your site, whether it's Bethel, whether it's Haynes, whether it's wherever you fall from. Where's Jennifer? Where are you working now? VA, okay, the VA, okay, so power on. And make these, you don't have to make big changes. We say the same thing that we say to patients with diabetes. Small changes can have huge effects, and I believe in trying to build the diabetes team with the patient in the center. Small changes, one change, could it be bringing foot exams into the room? Could it be instituting a CGM system in your system? Is it a way of tracking patients with A1Cs who need their labs done? Small changes will end with good patient outcome. And on that cheerful note, we finished 15 minutes early. Is there any questions directed towards me? Judy, would you like people to take a little stretch? Uh-oh. Okay, good idea. Don't stretch, guys. We'll have a longer midday break, okay? So thanks very much, guys, and I'll see you tomorrow. Okay, I'm going to take my thing away.